Welcome to The Explainer. Today, we're breaking down a critical, life-saving protocol for an acute neurological emergency, status epilepticus. In these situations, every single second counts, so having a clear, structured plan is absolutely essential.
Okay, so let's dive right in. What exactly is status epilepticus, or SE? Well, it's not just a long seizure. It's a true neurological emergency where the brain's own mechanisms for stopping a seizure have failed. That 5-minute mark you see, that's the critical line in the sand where a seizure is unlikely to stop on its own, and the risk of brain injury starts to climb.
So here's our roadmap for this explainer. We're going to walk through this entire protocol, step by step, in order. We'll start with the moment you recognize what's happening, move through the different drug therapies, and then get into the really advanced stuff, all the way to ongoing care. Let's get started. All right, phase 1. Let's talk about those first crucial moments. What do you do as soon as you identify status epilepticus? This whole phase is all about keeping the patient safe and getting everything ready for the treatments that are about to come.
The initial response is really a 5-step process, and a lot of this happens at the same time. You've got to recognize that you're dealing with SE. While you're doing that, you're kicking off basic life support, working to get IV access for medications, checking for any easily fixable metabolic issues, and of course, keeping a close eye on those vital signs.
Now, when we say stabilization, what does that actually mean in this situation? It's more than just the basics. We're giving supplemental oxygen to protect the brain. We're starting seizure precautions, like padding the bed rails to prevent injury. We're giving fluids to help prevent dehydration and muscle breakdown. And we're actively treating any fever because a high temperature can actually make seizures worse.
One of the very first things you've got to check for is hypoglycemia. Why? Because a dangerously low blood sugar can not only trigger a seizure, but it can also make it keep going. It's a simple check, but it is an absolutely vital piece of this puzzle.
And here's the magic number you're looking for, 60 milligrams per deciliter. If that quick point-of-care glucose test comes back below this number, you have to act immediately to correct it. No delays.
And here is the exact 2-part treatment for that. You give 100 milligrams of IV Thiamine first. This is super important, especially if you suspect malnutrition or alcoholism, because it prevents a serious brain condition called Wernicke's encephalopathy. Right after the thiamine, you follow up with IV Dextrose to bring that blood sugar up fast. Okay, let's move on to phase 2. We've got stabilization efforts underway, so now the focus shifts. It's time to use pharmacology to try and shut down the seizure activity itself.
This timeline really drives home the urgency here. The clock starts ticking the second the seizure begins. By that 5-minute mark we talked about, you should already be giving the first-line drugs. And if those don't work, you're not waiting around. You're immediately getting that second-line medication ready to go.
So what are these first-line drugs? They're your benzodiazepines. This table lays out your main options. Generally, intravenous lorazepam is what you want to reach for, mostly because of how long it works in the brain. But if you can't get it, IV diazepam or IV midazolam are solid alternatives to stop the seizure quickly.
Now, this is a critical point. If that first dose of benzodiazepines doesn't stop the seizure, we don't just give more and more. We escalate. We immediately move to the next line of treatment, which uses a drug with a totally different mechanism of action.
Okay, for your second-line drugs, the choice is important. But you know what might be even more important? The administration rate. Phenyane is a classic, but you have to give it slowly, no faster than 50 milligrams per minute, or you risk serious cardiac side effects. That's why its cousin, phosphenione, is such a great alternative. It can be infused 3 times faster, which is a huge advantage when you're racing the clock.
So what if the seizures still don't stop? You've given a benzodiazepine, you've given a full dose of a second-line drug. This brings us to a really critical decision point in the protocol.
At this point, the condition actually gets a new, much more serious name, refractory status epilepticus, or RSE. This basically means the seizures are resistant to the standard opening treatments, and it's a sign that you need a higher, more specialized level of care to break this dangerous cycle.
So when do you make that call? The criteria are crystal clear. If the seizures are still going after those first 2 drug classes, or if they stop for a bit and then come roaring back, that patient needs to be transferred to a center with advanced capabilities. We're talking an ICU with neurocritical care and continuous EEG monitoring.
All right, we're in phase 4 now. Imagine we're in the ICU of that specialty facility. This is where the big guns come out. More advanced monitoring, more aggressive treatments, everything needed to gain control. First up, protecting the airway is everything.
Intubation often becomes necessary, especially since we're about to use some very powerful sedating medications. And, just as critically, we begin continuous EEG monitoring. This isn't optional. At this stage, the patient might stop convulsing on the outside, but their brain could still be having damaging seizures on the inside. You can't see it without the EEG.
The next medication in our arsenal is phenobarbital, and just like phenytoin, it comes with a strict speed limit. You have to give it at less than 70 milligrams per minute. That's to manage its serious side effects, like respiratory depression and a drop in blood pressure.
Now, if even phenobarbital fails, the whole strategy shifts. The goal now is basically to put the brain to sleep, to induce a therapeutic coma to shut down all of that chaotic electrical activity. And we do this using continuous infusions of agents like midazolam, propofol, or pentobarbital, adjusting the dose based on what we're seeing on the EEG.
It's also worth remembering that you've got another tool in the toolbox. Valproate can be used as an adjunctive agent in this phase. Think of it as bringing in another player to the team, adding a different mechanism of action to help win the fight.
So let's say we finally gotten the seizures under control. You can breathe for a second, but the battle is not over, not even close. The focus now shifts to carefully managing the patient's sedation, while at the same time playing detective to find the underlying cause.
And this slide perfectly illustrates the two big jobs you have now. On one hand, you're carefully trying to lighten the sedation, watching the EEG like a hawk to see if the seizures come back. On the other hand, you're launching a full diagnostic investigation, scans, spinal taps, blood work, to figure out what caused this whole terrible event in the first place. Was it an infection, a stroke, a tumor? We have to find out.
Whew! We have covered a ton of critical information, lots of drugs, doses, and rates. So as promised, let's pull all of that vital data together. We're going to put it all on the screen for a final, comprehensive review.
Here's our first summary table, and it covers everything from that initial response. You've got the doses for thiamine and dextrose right there. You've got the specifics for our first-line choice, lorazepam, and you can see, side by side, the critical difference in those administration rates for our second-line drugs, phenytoin and fosphenytoin.
And this final table puts it all together for the advanced management of refractory SC. All the heavy hitters are here. Phenobarbital, your continuous infusions for that therapeutic coma, and the adjunctive agent valproate. Every essential loading dose and infusion rate you need is right here in one place.
So, what's the big takeaway from all this? Following a protocol like this gives us the absolute best chance to stop a life-threatening neurological emergency. But, and this is so important, controlling the seizure is just the first battle. The investigation into why it happened, that's just as critical for the patient's long-term outcome. It's how we can try to prevent this from ever happening.